She's a future leader in infectious disease modeling in South Africa, and she lives a passion for capacity building in modeling in Africa through her faculty role in the International Clinics for Infectious Disease Dynamics and Data, or ICI3D. At SACIMA, she's been working on the polio project, which she'll present on now, and also on dengue fever. And she's also working on methods to meaningfully use wastewater surveillance data in disease modeling. And with that, I'm handing over to Zinhle. I'll wait 5 minutes.
Good morning, everyone. As Kari has already introduced me, my name is Zinhle Mtomboti, and I'm a junior researcher at SACIMA. Today, I'm going to be talking to you about describing immunity gaps and the transmission potential for poliovirus in South Africa. And the work that I'm presenting is a work that is done by myself as part of SACIMA's modeling and analytics response team. So before we go further, I would like to start by introducing the team. So that's the team members of SMART. SMART, as we call it, which is SACIMA's modeling and analytics response team. It was launched in, So it was launched in February 2022. And its goal is to actually sculpture confident, competent, and a cohesive team that can support public health decision makers during real-time outbreak situations. And as you can see, the team primarily consists of junior staff. And today, as we delve into the presentation, you will actually get to witness some of the work that has been produced by the SMART team. Okay, so this is myself and Dumelo, and this is the team that mainly work on the transmission model. And then this is Jeremy and Lauren, and this is the team that mainly works on the immunity estimation process, which I'm also going to be talking about today. So to get started, we will start by looking at circulating vaccine-derived poliovirus 2, which will be referred to as CVDPV2 onwards on. And we will talk about why are we concerned about it. And then I'll also go through the estimation of the immunity estimation process. Then we will move to wild poliovirus 1, which is WPV1. Again, we'll talk about why are we concerned about it, the transmission dynamics, which will be using the transmission model that we developed. And we also did some scenario analysis in case of an introduction. So we will start by talking about why do we actually need to estimate immunity? Do we not already know what are the immunity levels like, and why did we feel that we needed to come up with this new process? So the proper estimation of immunity is very important if we do actually want to get to a point where we eradicate polio. So currently there is what is referred to as zero-dose children. And zero-dose children refers to children who have never received any vaccination at all. But to calculate the number of zero-dose children, they use a proxy. And the proxy usually just calculates the number of babies who did not receive the first DTP1 vaccination. So that's the proxy that is currently used. But what we want to do, or what we are doing, is to actually assess the actual immunity levels in the community. So not just looking at how many babies miss the first dose, but actually what are the levels of immunity in the community. So this leads to precise regional risk assessment. And knowing this will also lead to informed public health planning, because we will be able to actually identify the susceptibility in the population. So this is us moving beyond just saying beyond saying how many children miss doses, but to actually say, in terms of immunity, how many people are actually protected. So like I said, we will start with CVDPV2. And as we know, it continues to circulate in Africa. And in Botswana, earlier in the year, it was detected in environmental surveillance. It was also detected in Francistown earlier this year. So the risk of importation is high. We have ongoing transmission in the region, as I've already mentioned. We also are concerned because we have a lot of movement and migration between South Africa and these countries. And also there is suboptimal immunization, as you will see. And as Kerikan has mentioned, in 2016, there was this switch that actually removed PV2 from OPV in the EPI schedule. And before we go further, I would like to start talking about the immunity estimation process that I said we have developed and we are using instead of just using the coverage estimate. So first of all, we need data, that is vaccination data. So we got vaccination data from the National Department of Health, but there were some gaps, especially for the Western Cape. And to fill in those gaps, we used the Western Cape Department of Health data. We also needed our population data. So we got data for live births from Statistics South Africa. And we also used the population size was estimated from the Tembisa model. So data on IPv1, IPv3, and IPv4 were complete for the time period that we are interested in. But there were some missing data for IPv2. Therefore, to actually get the number of doses for the missing data, we use this bootstrap method where we actually impute to get the missing data. And once we have a complete data set, we are able to then distribute the doses using the live birth data that we actually got from StatSA. This then leads us to have the zero dose babies estimates. And once we have, once we distributed, then that's when we estimate the zero doses babies. And then in order to actually get the exact levels of immunity, we go a step further by actually applying efficacy of the IPV. And then that then tells us how many people got vaccinated, and out of the ones that got vaccinated, how many actually got immune from the vaccination. Then from there, we get the district level immunity estimates, which is what we are interested in. So in this case, we went a step further from saying these are the babies that were vaccinated, but we actually went and said, out of the babies that were vaccinated, how many were actually protected in terms of how many actually had immunity. So then to validate the work that we have done, we then compared the results that we got with the data that we have from UNICEF and WHO UNICEF, which is referred to as WUNIC. So if you see in the graph, your y-axis is the number of zero dose babies, and your x-axis is the year which they were born. And the pink is SACIMA, the blue is UNICEF, and then the dark blue is actually WUNIC. So if we can see here, we see that the estimate of zero dose babies, when we use our distribution assumption, actually aligns with the UNICEF proxy measure and the WUNIC data. So we're going to be mostly looking at the city of Johannesburg as an example. And again, this graph here, your y-axis is your population, and then the x-axis is your birth year. So here we want to answer questions such as, what are the gaps in immunity to PV2? And again, we are concerned about PV2 because we removed OPV2 from the EPI schedule in 2016. And in this case, we have susceptible to infection. As it's already been mentioned, if you are vaccinated with IPV, you are susceptible to infection. So you can still get infection and you can still transmit, you just cannot get the disease. And then in red, we have the children that are fully susceptible. And these are the children that the zero dose babies that we talked about, plus those that the vaccine did not take. They got vaccinated, but they were not immunized. And again, as we have already mentioned, IPV does not boost gut immunity, and it does not lower the presence of poliovirus in stools after exposure. So as Kerrigan has already mentioned, if someone has IPV, if they get exposed to OPV or get exposed to the disease, they can still get the disease, they can still get the infection, and they can still transmit. So again, this is us just looking at what disease are actually mostly at risk, and these are the top 9 districts that we have. And again, we have the population on the y-axis, and then we have the birth year. So in terms of PV2, due to the lack of OPV since OPV2 since 2016, we can see that there is a substantial risk of transmission in under 5s, and this is going under-recognized if we are using the traditional metrics such as zero dose babies. Okay, Then we will move on to wild poliovirus 1, which I'll be referring to as WPV1. And again, we'll go through the reasons why we are concerned, the transmission dynamics, and then the scenario analysis. So Africa, as it's already mentioned, it was declared polio-free in August of 2020. But in 2022, we saw importations of WPV1, which were detected in Malawi and Mozambique, which is a reason for concern for South Africa, because again, those are countries that we have a lot of contact with. So the risk of importation due to suspected ongoing transmission in the region, and again, because of movement and migration, and as we've already said, we have suboptimal immunization. Therefore, we are concerned as to like what happens then if it is introduced to South Africa. And some of the questions we can ask again is, what are the gaps in immunity to WPV1, and which districts and age groups are most at risk? So this is the city of Joburg. Again, the first one we saw was for PV2, and then this one is for PV1. So you have this your y-axis here is the population. Again, we're looking at the city of Joburg. Your x-axis is the age groups. So these age groups are 0 to 4 year olds, or they are in the age bins of 5. So if we look here, we have the gray, which is the population that is fully immune. So these are people that cannot be infected at all. Then you have the susceptibles, which is in purple. And these again are people that are only susceptible to infection only. And then the last one we have is the one in red, which is fully susceptible. So this again is either those who never got vaccination or the ones who did get vaccination, but for whatever reason, the vaccination did not take. And if you look, we can see that we have a high proportion of children that are either susceptible to infection or fully susceptible. These are the under 15s. And then this goes back to the fact that this is when we have we had removed PV2. So then we need to also estimate the immunity gaps by district for PV1. And the graph that we are seeing now is the proportion that is fully susceptible of under 15-year-olds for the country of South Africa. And you can see that in some districts it goes as high as 30. You have like about 30% of under 15-year-olds actually fully susceptible. And then if we look at the proportion that is susceptible to infection only, so these ones don't have gut immunity. Again, you can see that this one is even higher. It goes as high as 60%. And if we were to highlight a few, we have Dr. Kenneth Kaunda, which has about 30% of under 15-year-olds that are fully susceptible, and about 66% of under 15-year-olds that are susceptible to infection. And then the next one that we have that it's also at risk, it's actually eHlanzeni, which is in Mpumalanga. And you can see that for fully susceptible, we have about 28%. And also those that are susceptible to infection, we have about 62%. And these are also districts that were mentioned in terms of Elizabeth's presentation as districts of concern. Okay, so now we have develop this new method and we are able to actually estimate immunity, right? So what do we do with that, and how does it fit in terms of the transmission model that we are actually trying to develop? So we developed this polio transmission model, and it was done in collaboration with the NICD and with input from some of you as well. So the goal of this model was to evaluate potential interventions against WPV1 and CVDPV2 introduction in South Africa. I will go into more detail as to how we then include the immunity estimate and what this pretty diagram actually means. So this is an age-structured compartmental model. And the initial focus when we started working on it, it was WPV1, because we started developing it after the cases were detected in Malawi and Mozambique. We then created scenario analysis, and the first scenario is a reactive SIA. So whenever a case is detected, by the guidelines that we need to follow to actually have an SIA where we react due to the case that's been detected. And by SIA, I'm talking about supplementary immunization activities. And then the next one we are doing is a preemptive catch-up campaign, because we've already seen that our immunity levels are quite low. So we're creating a scenario where, like, what happens if we actually do a preemptive campaign? How well can we improve our immunity levels? And then what we are actually interested in, which are the model outcomes, are the number of underlying and detected AFP cases per scenario I've just described. So going back to the model and how it relates to the immunity estimation process I spoke about. So in our model, when we start, we already know that there's the vaccination that is going on in terms of EPI. So which means we already have people in the community that are vaccinated due to routine vaccination. So we then have those 3 compartments where we are dividing our population according to infection and vaccination history. So the first group we have, which is our S, that's the population that is fully susceptible. The next group that we have, which is our VH, this is the population that has humoral immunity only, that is, they were only vaccinated with IPV. And then the last one that we have is the group that is fully protected. So these ones have both mucosal or gut and humoral immunity. So they were either vaccinated with both IPV or OPV, or they've had the disease before, so they are fully protected. So these estimates, to initialize our model, we are actually getting them from the immunity estimation process that we used. So in terms of the model, we're just gonna keep S, which is our fully susceptible, VH, and then our G. And this, like I said, this model is stratified by age. As you see, we do have like different age groups. And then the way we know there's no circulation of polio in South Africa, but we have to introduce the disease somehow into the model so we can see the different dynamics. So the way that we introduce the disease is actually through an exposed individual. So we have one exposed person who gets introduced into the population, and then this person goes through the transmission route where they become infectious, which is our I, and then they move to G, where they are now fully protected because they have recovered. And since we now have infection in the model, we have that our susceptible people, which are our S, they are also becoming exposed, and then they are becoming infectious, and then they recover and they move to G. But remember, we also have the VH compartment, which we said are the people that have IPV. And we said that these people, as much as they cannot get the disease, they can get the infection and they can still transmit. So they go through the same process, they become exposed, they become infected, and then they move to G, where they are now fully recovered. So in this model, as I mentioned, whenever a case is detected, we need to have an SIA, right? So as you know, only 1 in 200 cases of polio actually get detected. So then we need to know how many AFP cases do we have in this community? And out of those AFP cases, how many get detected? So we have what we call our counter variables. Our A refers to the number of AFP cases, and our D refers to the number of detected cases. So once we have a case that is detected, we follow the guidelines that now require us to actually have an SIA, which then in the model is the green part that you are seeing here. So you have your susceptible people that will get vaccinated with OPV. Oh yeah, I forgot to mention, in this whole study, we are assuming that our SIA is done with BOPV. So we have the people that will now be vaccinated with BOPV, and then they will go through the same process again. They'll be exposed and infectious, and then they will recover. And again, as we've already said, these people have only had IPV, so they also go through the same process until they are fully recovered. So that's the model that we have, and that's the model that we're using. So the model is run separately for each of South Africa's 52 districts, and it's based on district level characterization. And we're looking at the population, age structure, and the age structured immunity profile. So this is not perfect. This is work that that's still in development. So it does have some limitations. Part of the limitations are that we have full parametric uncertainty is not captured in these outputs. We are only uncertainty that is captured so far is through the age structured immunity profile. This is a deterministic model, and it represents the average dynamics in the event of an epidemic. We've made some simple assumptions about surveillance processes. We assume that about 80% of AFP cases are detected across districts, all districts and age groups, and we don't yet account for environmental surveillance. So having had this model, having had the immunity estimation, these are some of the questions that we can ask and we can answer with the model that we have. So we are asking questions such as, in the event of an WPV1 epidemic, what age groups would have the highest number of AFP cases? Also, what age groups would actually be driving the transmission? And again, we go back to the model and also making use of our immunity estimate. And we can see here, this is our relative force of infectivity in our y-axis, and we have weeks since introduction in the x-axis. And from the model, we saw that the 5 to 19-year-olds are actually the ones that will be driving our transmission. Again, we can ask questions such as, what age groups then should then be targeted for the SIA, right? We said, if we detect a case, we need to do an SIA. But what age groups should we then target? Should we go for everyone? Should we go for 0 to 4-year-olds? Again, we can go and consult the model to find out about that. But this will be guided by the Polio Global Eradication Initiative. So some of these decisions, we need to follow the guidelines from here to come up with the scenarios that we have. So they recommend that you do a rapid response less than 14 days of day 0. You do your first SIA without less than 28 days of day 0. Your second SIA less than 42 days of day 0. And finally, you do a mop-up campaign. So motivated by this or following these guidelines, we create 2 scenarios. We are saying we could have an optimistic scenario where we could have our rapid response will be targeting up to 400,000 people. Our first SIA and our second SIA will have an achieved coverage of 95%. Or we could have a not so good scenario where now our rapid response will target up to 200,000 people. Our first, second SIA will have an achieved coverage of 75%, and we'll also need a mop-up campaign of 75%. As I've already mentioned, we are assuming that we will be using BOPV for these reactive SIAs. So then the GPEI recommends that when you do an SIA, you actually target 0 to 4-year-olds. But using the model, we actually found that in most districts, if we expand the age groups, we are then able to substantially reduce the number of expected AFP cases. And the last question we can ask is then, in terms of doing a preemptive campaign, we've seen that we have immunity gaps, our vaccination rates are low. If we were to do our own preemptive campaign, which age group should actually be targeted? Again, we create a new scenario. We are saying, in this case, we're using BOPV because NOPV was not approved yet. I guess some of the things we will do now is to actually use NOPV. But for now, these results are based on BOPV. And we are saying, let's target under 15s. And then the achieved coverage in this case is 65%. And we saw that if we use a preemptive BOPV catch-up campaign in 0 to 4-year-old, we will go a long way towards closing the immunity gap that we've already seen in the previous slides that I've shown you. And then in summary, we saw that there is a substantial gap in mucosal immunity, and then this increases the risk to those who are fully susceptible. And we saw that in the event of a WPV1 epidemic, we expect that the highest number of AFP cases will be between the 10 to 24-year-olds, and we expect that the 5 to 19-year-olds will be the one that will be driving transmission. And then if we are to actually do a reactive SIA after a case is detected, we should have a fast and strong, which is the optimistic scenario. But again, if we target the 0 to 4-year-olds, we have limited impact compared to if we have the fast, strong, the optimistic scenario, but we now target the 0 to 14-year-olds. And then in terms of what age groups, in terms of preemptive, again, if we actually do target 0 to 14-year-olds in terms of helping with closing the immunity gap, that made a substantial difference. So what does this mean then for public health, right? So we need to strengthen routine immunization in order to reduce the immunity gap. Enhancing environmental surveillance is key for earlier detection, which will then lead to earlier action. Carefully consider benefits versus risk of preemptive campaign with BOPV, which I guess in this case we have to now consider the benefits of NOPV. And the immunity gap for VDPV2 is even larger for WPV1, which is also because we removed PV2 from the immunization in 2016. Then what are the next steps? We need to do additional sensitivity analysis. We also want to consider an environmental surveillance scenario, and which was great news because we had that in the previous talks. They are now considering having environmental surveillance in most of these countries, which means we will actually have the data to add that to our model. And most importantly, we are recommending that we focus on 0 to 14-year-olds instead of 0 to 4-year-olds as currently recommended. We need to do a cost effectiveness of that to see if the cost is actually worth it, and we will do that in collaboration with NICD and HERO. And we also need to look at a full age structured immunity profile for PV2, and we also need to do the same thing we did for WPV1, which is looking at the transmission dynamics and scenario analysis for CVD PV2 as well. And as I said, this is not work that was done by me alone, so I would like to thank everyone for all their contributions in this work, and thank you so much for your time.